Well, hello everyone. This is a huge room and I'm thrilled to be here. So when Bob asked me to talk, I said, but this is all pearl, these clinical pearls, and I'm a neuroinfectious disease doctor. And all my patients are lethargic or coma. So what I decided to do was to tell you what I have learned in 25 years with my sleeves rolled up. And I'm going to give you all the secrets. Now, only you guys should share these secrets. Don't you? If you didn't take this course, you just aren't going to know. And I'm thrilled to see Whitney and Delanji. Welcome. So I have to make sure I can use this. So I have nothing to disclose, and I have no conflicts of interest. So we're going to start with a patient, and then we're just going to roll from there. And I'm going to just give you all the secrets. So this is a 22-year-old who presents to the emergency room complaining of fever, vomiting, and headache for 12 hours. So fever and headache. And Bob was just making a reference to the fact that we don't ask about stools. I mean, if we cared about vomiting and stools, we certainly wouldn't be neurologists, right? I mean, both bad. But vomiting without diarrhea, think about CNS infections. Should we think about bacterial meningitis? Absolutely. Fever, headache, vomiting. So we debated for years if you have to have the classic triad of fever, headache, and stiff neck. And there's been this controversy in the literature that some patients don't have stiff neck. So after a lot of debate and discussion, we arrived at the decision that you had to have 2 of the 4 following symptoms and signs: fever, headache, stiff neck, altered level of consciousness. And then again, vomiting is often a symptom of bacterial meningitis. So what do you do faced with these patients? What's the first thing that you do? You don't send them to the scanner. Nowadays, I know that everybody gets TPA. Well, we don't do that either. But what we do is we begin with just grabbing some blood for CBC and gram stain, sending serum procalcitonin and C-reactive protein, and that is a secret that I'm going to share with you that will help you in telling the difference between bacterial and viral meningitis. And you begin empiric antimicrobial and adjunctive therapy. So how is the C-reactive protein helpful? In patients in whom you're thinking it's either bacterial or viral meningitis, in that group, it is helpful in that a normal C-reactive protein has a high negative predictive value for bacterial meningitis. So add it to your group of tests that you do, just because of the trying to make the decision between the two. The procalcitonin is a nice test that increases in patients with any sort of severe bacterial infections. And again, we are always in search in the first 24 hours of how to tell bacterial from viral meningitis. So you've got your C-reactive protein, negative against bacterial, and then you have your procalcitonin, positive in favor of. Bacterial meningitis, the organisms that have caused it have not changed in my long career in neurology. I won't say how long, but 25 plus years. The most common causative organisms of community-acquired bacterial meningitis are the pneumococcus and the meningococcus. That's not changed. Now, all of the young people in the room are thinking, I'm really happy because I got the meningitis vaccine and I'm safe. And I don't mean to ruin your morning, so don't let this happen. But it does not contain serogroup B. You got the tetravalent meningitis vaccine. But 1/3 of cases of meningococcal disease are caused by this serogroup B. And you know the outbreak at Princeton, that was serogroup B. There's a recent case in this past week's New England Journal of Medicine. The patient had serogroup B. So just be on the lookout for it. I just wanted to show you what someone looks like who has meningococcemia. This is such a classic rash. If you detect this early, treat it quickly, these patients do beautifully. If we don't, it usually leads to limb amputation. So we want to really be able to recognize it. Similarly, there's a pneumococcal vaccine. And right now, the big one is this PCV13 Prevnar that you see on TV, the conjugated vaccine. This is not a meningitis vaccine. It is a pneumonia otitis media vaccine, and there are 90 different serotypes of the pneumococcus. So we still have a lot more to do. But if you do have a 55-year-old plus adult who wants to ask you if the pneumococcal vaccine is safe, all of the conjugated vaccines are safe. They don't cause autism in 55-year-olds. So just, go ahead and reassure them that they might want to get it to prevent their pneumonia. But beware that while we're working on vaccines, the organism is, of course, working on serotype replacement and kind of trying to stay one step ahead of us. Think about predisposing and associated conditions. I only want to tell you this because now that we recognize the role of anaerobes in patients with otitis and sinusitis, that's going to be an issue for us as well. Empiric therapy, so you're in the ED, you've sent your CBC, your blood cultures, your C-reactive protein and your serum procalcitonin. They're not going to come back right away. You're going to start treating the patient. And what are you going to treat them with? Well, you're going to treat them with ceftriaxone, most likely, 2 grams every 12 hours, plus vancomycin. The dose of vancomycin is really important. We want to get CNS penetration of vancomycin. You can also give intrathecal vancomycin, perfectly safe. Patients won't seize. It's a beautiful way to give it as well. So we have vancomycin. We're also going to give acyclovir, fever and headache. We're thinking about, could it be herpes simplex virus encephalitis? We haven't yet got to our diagnostic studies. We're going to treat and then work it up. Plus doxycycline during the season when patients are at risk for rickettsial infections. And then you add ampicillin for patients that are over the age of 55, pregnant women, immunosuppressed. Where do you get listeria? I could not believe it. In the hallway. Did you guys see the cheese sitting out there? So could you guys believe this? I am like, oh my goodness. So you get listeria from walking out that door and taking a plate of that dried up frickin' cheese that's sitting out there, and you're sitting here, and then 24 hours, you're going to start having vomiting and diarrhea. And if you're over 55, you're going to get a fever and headache, and I'm going to have to rescue you. So you have my email, should that happen. But there's like 10 plates of cheese out there. I don't think they'll be there next year. So just remember, if your patient has otitis or sinusitis, you're going to think about anaerobes and add metronidazole to your empiric therapy. And why do we prefer meropenem to imipenem nowadays as empiric therapy for neurosurgery patients and such? Well, basically, imipenem has a seizure proclivity that's pretty high. And meropenem is more active against gram-negative pathogens. So that's our drug that we use in place of ceftazidime for our neurosurgical patients when you're looking through your handout. And just to remind you, intraventricular vancomycin for the patient that isn't doing well, safe and effective. Okay, so then the question and debate has come up since at least sometime back in the 90s, and about whether or not dexamethasone should be used with the first dose or before the first dose of antibiotic. We're neurologists, so we don't want to just eradicate the meningeal pathogen. We want to preserve personhood. I don't want to just survive my disease. I want to survive as Karen Roos. I want to be able to think and work and keep going. So we have to make sure that we're always looking for what causes the neurological sequelae. I did this algorithm in 1985. I presented it at the ANA. And people said to me, you know, if this doesn't turn out well, your career is over. So for all the young people in the room, don't worry about it. It's going to all be okay. I couldn't give you this because I think Harrison's owns it. We put it in Harrison so many times. But the important point is that once the meningeal pathogens get in the subarachnoid space, they multiply. You have release of bacterial cell wall components and the production of inflammatory cytokines. That step leads to all of the neurological sequelae, whether it's hydrocephalus, stroke, seizures, coma, apoptosis, all of the neurological sequelae. All of us are concerned with the neurological sequelae. Dexamethasone inhibits the production of the inflammatory cytokines, IL-1 and tumor necrosis factor, which have been the bad guys in inflammatory diseases for as long as I can remember, and are the targets of biological therapy for so many inflammatory diseases today. Dexamethasone also stabilizes the blood-brain barrier. And so when we wrote the guidelines as part of the Infectious Diseases Society of America, we recommended dexamethasone for all adults with suspected or proven pneumococcal meningitis. The European Federation guidelines added Haemophilus influenza type B, which we didn't add because we don't see a lot of that anymore given the number of children that have been vaccinated, although that could be a problem in the future. And then we also added this comment. We said, you know, you really can add dexamethasone because you don't know what the causative organism is early. And some people said, well, you know, what would happen though? What would happen if patients had meningococcal meningitis? And then a paper came out in Neurology by Heckenberg that dexamethasone actually demonstrated a favorable trend in reduced rates of death and hearing loss in patients with meningococcal meningitis. So go ahead and use Empiric antimicrobial therapy and dexamethasone, and now we're going to do the workup. Remember, dexamethasone needs to be administered prior to or with the first dose of antibiotic. So the next thing that we're going to do, we used to debate about whether or not we should do a CT prior to an LP. I like those debates. You know, again, that was back in the 80s. I had big hair, leg warmers. John Travolta was doing Saturday Night Live. It was all fun. But nowadays, everybody's image as they hit the ER door. And so that discussion's kind of gone out of favor. This is how I think through in my neurology OCD brain, what I want to do for diagnostic studies. This is my little computer chip. So of course our routines and our stains and culture. I rarely actually do viral culture. I used to do it for Enterococcus until that RT-PCR became so rapidly available that I rarely do it nowadays. Remember that CSF gram stain takes minutes, and the culture usually takes hours to days. But if you call the lab and they set the culture up under lights, you'll get a result very quickly. There is a PCR available. It's a broad-based bacterial PCR. If you ask for it enough, you'll get it. That'll be good in patients pre-treated with antibiotics. If I only were limited, and everyone said to me, You can only have 4 PCRs for meningitis. What 4 might I like to order? I think this is going to increasingly become important for us because we can no longer do the latex agglutination tests, so we need something for patients that have been pretreated. Always order this RT-PCR for enteroviruses, very sensitive, very specific, back in 4 hours. You're going to want to order PCR for HSV1 and HSV2. And the PCR for M. tuberculosis is now called the nucleic acid amplification test. This is a PCR that keeps changing as we look for a more sensitive and specific PCR. Should you order a lactate concentration only in the neurosurgery patient? So otherwise, no. But you're going to want to get a CSF lactate concentration in the post-neurosurgical patient because in those patients you're trying to decide between infection and just kind of the chemical changes post-op, and that lactate is going to take you over the hump. Do that one. Okay, let's do the secrets to viral meningitis. As neurologists, we all know patients have fever, headache, stiff neck, vomiting, photophobia, no alteration of consciousness, no focal deficits, no seizures. So these are the 4 tests that I think are most helpful in trying to make a distinction between bacterial and viral meningitis. Get the C-reactive protein, the serum procalcitonin, a CSF gram stain back in minutes, the RT-PCR back in 4 hours. So put a star by that on your PowerPoint in your handout. Viral meningitis is caused by 4 viruses, 4 groups of viruses. The most common are the enteroviruses. Where do you get those? You get those as soon as you dive in a swimming pool where children have been pooping. So it's chlorinated poop plus enteroviruses, and you just suck in a big mouthful of enteroviruses. Where do you get herpes simplex virus type 2? Well, we talk about this frequently amongst the ID group. For all the young people in the room that are dating for reasons that are unclear, 74% of patients in all cumulative studies with genital herpes don't know they have it. Just a little mom warning talk for the morning. So just be aware of that. HIV and then mosquito-borne viruses. So I don't know what's going to happen with mosquitoes this season, but last Saturday night, my future son-in-law came in the back door and brought in 15 mosquitoes. And, I like the guy, but the mosquitoes, bringing in the mosquitoes was like not going to happen. So what are the enteroviruses? You're all familiar with them. Those are Coxsackie viruses, echoviruses, and those viruses identified by number. D68 is the one with recently that caused the epidemic of the upper respiratory infection, and some of the children became paralyzed. So how do you actually make the diagnosis of an enteroviral meningitis? Again, by PCR, but an important caveat here is that for the first 24 hours, there may be polymorphonuclear leukocytes, but your glucose concentration will be normal. Polys with a normal glucose concentration. There's no specific antiviral therapy, but patients do feel better with nonsteroidal anti-inflammatory agents and amitriptyline. Now, send serology. So for both enteroviral infections and arthropod-borne viral infections, when you first see the patient, get IgG, acute serology. Have the patient come back 4 weeks later and get convalescent serology. You will see a 4-fold increase in the specific enterovirus. So it'll come up as Coxsackie before, echovirus 71. And patients always say to me, Dr. Roos, you're smarter than Wikipedia. I'm like, yes. So it really reassures the patient nowadays to know exactly what the virus is. So that's very important. For herpes simplex virus type 2, I've forever been looking for this in CSF. The PCR is often positive just early, so by the time you see the patient, it may be negative. And culture is only positive when you have meningitis during primary HSV2. And then you can or cannot treat these patients. I think nowadays most of us feel like we want to treat them because they do want to be treated. It shortens the duration of viral shedding a little bit, and patients do feel better sooner. These are the patients also with recurrent lymphocytic meningitis who eventually are going to then themselves want to initiate. I prefer valacyclovir to famciclovir, much better CNS penetration. HIV, even if you have an HIV-infected patient with a good peripheral, very low HIV load, send their CSF. Tends to be a lot higher. It will change their antiretroviral therapy. You're doing them a big favor. Mosquitoes, again, like enteroviruses, there may be a polymorph nuclear leukocytosis early in infection. Patients with West Nile virus meningitis may have a persistent CSF neutrophilic pleocytosis. So don't let that throw you off. Again, it's polymorphonuclear leukocytes with a normal glucose concentration. The best test for West Nile virus, any type of brain infection, meningitis or encephalitis, is the CSF IgM. The PCR has a sensitivity of 25%. And again, you're going to send your serology, very helpful in identifying what mosquito-borne virus is the causative agent of the meningitis. Remember, we want to look at IgM. So now we're going to do some of the pearls and the pitfalls in CSF diagnostic studies. What actually Dr. Horn and I are working on is trying to show in Cerner, along with Dr. Shear, what tests are useful and which ones aren't. You know, and it would be so nice under a comment section if we could come up with, this test has a sensitivity of 25%, so that every clinician would know. So one of my clinical pearls is never underestimate the value of acute and convalescent serology. Never underestimate that. That can give you the virus. Be aware of the sensitivity of the CSF PCR for CNS infections. Now here's an unfortunate secret given the cheese in the hallway. The identification of Listeria as the meningeal pathogen is best done by blood cultures. Very hard to get this from CSF. So if you had the cheese, you get the vomiting and diarrhea. I think we'll maybe have a blood culture station I'll set up tomorrow, the next day, maybe out here somewhere. And we talked about this, so arthropod-borne virus, polymorphonuclear leukocytosis early with a shift to a lymphocytic pleocytosis. The greatest mimic for bacterial meningitis is medication-induced meningitis. And unfortunately, this group is growing and growing. Patients with medication-induced meningitis look just like patients with bacterial meningitis. Fever, headache, they can even be comatose. And their CSF has an elevated opening pressure, polymorphonuclear leukocytes, and a decreased glucose concentration, but the Gram's stain is negative. The key being that when you remove the offending agent, the patient is better in 24 to 48 hours. This list continues to grow. primarily because of epidural injections of all sorts. And I'm very disappointed that my all-time favorite antibiotic group has finally joined the list. But just think about this. The clinical presentation is so strikingly similar. But the gram stain is negative, the serum procalcitonin is negative, and you remove the offending agent and the patient gets better. It's just unfortunate that in medication-induced meningitis, the CSF spinal fluid analysis is so threatening. I think anytime you have polys and a decreased glucose concentration, that is a worrisome CSF. Encephalitis, the secrets to encephalitis. Okay, here's some critical secrets that are really, really important, and I'm going to show you what. The best test for HSV encephalitis is diffusion-weighted MRI. And you can expect to see that in 90% of adult patients within 48 hours of symptom onset. And I think you got this in your handout. Look at the difference. If you look at flare, T2, DWI, that's the test you want. Another important point. The CSF HSV PCR may be negative in the first 72 hours. Now, in our hospital system, we have the nighttime ghost of a cyclovir discontinuation. So if you tap a patient and their PCR comes back negative, this ghost comes through and DCs the acyclovir. No one's ever seen this person, and the only reason we know they exist is because my outstanding residents show me in the morning that the acyclovir has been discontinued. So it's really important that we stay on top of this. And if you, the neurologist, thinks this is HSV encephalitis, keep treating, and you can repeat looking for a positive PCR. You can also, if the patient gets to you after about a week or so, look for antibodies. And I think that the antibodies are also helpful. You can do an antibody ratio, looking for serum to CSF antibody ratio of less than 20 to 1. But the antibodies take about 8 to 12 days. So it's diffusion-weighted imaging, PCR is negative, repeat after 72 hours, and then at day 8 start sending antibodies. And of course, the treatment is for 3 weeks. Okay, here's some pearls. This is actually going to help you, I think, this summer, given, the mosquito attack that we had last Saturday night. If you look at this, so we said we want to send CSF IgM for West Nile virus encephalitis. Look at these secrets. The test may take a week or longer to be positive. The prevalence of positive CSF IgM increases by about 10% per day. So that's something that should pop up in the electronic medical record. Wouldn't that be helpful? I mean, I think it'd be a lot more helpful than medication reconciliation that we have to keep hitting that, button on. These kind of things would help us to understand the limitations of our diagnostic tests. VZV, again, look, it's the IgM. CSF PCR for VZV DNA is positive in approximately 30% of cases. So again, the PCR is not always the best test. It's just one of them. This is just something to put in the back of your mind. If you see a patient with an acute febrile illness, let me emphasize, acute febrile illness with brainstem signs and symptoms, there are really only 5 causative organisms: herpes simplex virus type 1, listeria, the flaviviruses, which include West Nile, St. Louis, Japanese encephalitis virus, Enterovirus 71, and rabies. Just a little factoid. But you all know, if you see a person with encephalitis with involvement of the basal ganglia and thalamus, think flavivirus, West Nile, St. Louis, Japanese encephalitis virus. What are some of the encephalitis pitfalls? Again, this test may be negative in the first 72 hours of symptoms. So stick with your guns. If you think clinically it's herpes, your diffusion-weighted imaging says it's herpes, Go with it. The CSF PCR for West Nile virus is a pitfall in its low sensitivity. The CSF PCR for varicella zoster virus is a pitfall in its low sensitivity, so use the IgM. And then there's this troublesome Epstein-Barr virus. So, you know, for all of us that got mono at some point in our lives, our Epstein-Barr virus is floating around. It's in all of our mononuclear cells. And so whenever you tap a person, you can have a positive if they have an inflammatory reaction. If they have an inflammatory reaction, they can have a false positive Epstein-Barr virus PCR. I only believe that it's a true positive Epstein-Barr virus PCR in patients with primary central nervous system lymphoma and patients with EBV lymphoproliferative disorder. But otherwise, you have to look at serology. So you're going to want to go back to what you learned years ago with looking at VCA, IgM and IgG, and EB and A. But don't trust this as the cause of the CNS infection. Lyme disease. I thought as we finish off the morning, everyone was probably dying to know about chronic Lyme disease, right? It's kind of like one of the hottest, now that the celebrities have it, they're all running around with it. And in a complete unbelievable situation, our daughter actually lives in Connecticut, so amazing. Okay, so the patient comes to see you, and everyone thinks they have Lyme disease, no matter what's wrong with them. They have fatigue, Lyme disease. They have a headache, Lyme disease. They have vertigo, Lyme disease. What do you want to ask them? Well, the first thing that might be a good question is that, were you bitten by a tick? And before I go any further, I just wanted to mention that when, you know, the national news a couple nights ago was talking about how these ticks have a new virus. It's the Powassan virus. We've known about that forever. So I think the national news is behind the neurology community. I tweeted them. So anyway, so you have, with Lyme disease, were you bitten by a tick? That's the first thing. Did you have, I'll show you this lesion. Did you have a slowly expanding erythematous lesion? This time of year until November, my inbox lights up with patients all over the country sending me pictures of bug bites in all places on their body. And so I open my inbox in the morning and there's like 10 new bug bite pictures. They want to know what it could be. It doesn't itch and it develops the appearance of a target. That's what it looks like. So ask the patient, were you bitten by a tick? Did the tick feed longer than 24 hours? And did you have this lesion? And of course, were you in an area endemic for Lyme disease, which is the northeastern United States, Minnesota and Wisconsin, and California, right? So, what does nervous system Lyme disease look like? You can present with a unilateral or bilateral Bell's palsy, a lymphocytic meningitis, or a painful radiculitis, which is sort of part of the mononeuropathy multiplex syndrome. So how do you work this up? And this is really critical. The first thing you do is send an ELISA, and do not use the Lyme labs. Do not. You know what labs always come back positive. And they usually come back from a state whose name I will not mention, but they're having a drought, big state, wine country, real pretty place. So don't use those labs. There's nothing worse than a bad lab. It just gives fog to the diagnosis. If the ELISA is positive, then the Western blot. ELISA first, positive, then the Western blot. If you're going to tap the person, you can send, you expect to see in nervous system Lyme disease a lymphocytic pleocytosis with a normal glucose concentration. We also talk a lot about doing the Borrelia-Burgdorferi antibody index. You can't just look for antibodies to Borrelia in the spinal fluid because people with Lyme infection for any reason will have them there as well. It's kind of part of their normal brain flora after a while. And we refer to this as a European way because the Europeans often do the antibody index. That's how they prove CNS neuroborreliosis. And that's what it looks like. You can calculate it yourself. You can ask the lab to do it. But in any time you're looking for intrathecal antibody production, it's the organism in CSF over the organism in serum as the numerator, total IgG in CSF over total IgG in serum as the denominator, and the antibody index is positive when the result is greater than or equal to 1.3 to 1.5. So, but let me tell you the secret. You get the ELISA, it's positive. You get the Western blot, and some of the IgM bands are positive. All of us have some positive IgM bands on that Western blot. What should happen, however, is those IgM bands become IgG bands. So if you have a patient with positive IgM bands, you don't want to tap them, you should expect to see positive IgG bands on the Western blot. You can now treat Lyme disease, meningitis, facial nerve palsy, radiculitis with just doxycycline. We actually, I think in the new guidelines that will come out that are presently underway, we're going to get rid of ceftriaxone. Everybody gets better. So what do you do with the patients with chronic Lyme disease? What do you do with them? These are people that have so many different things. I think the most important point here is you cannot use the Lyme lab. I use our State Board of Health because I think that's very, very reliable. Please just don't do the Lyme labs. That's a real problem. And then again, these IgM bands, within 1 to 2 months of disease onset, you will see positive IgG bands. Okay? Now, if your patient, however, still isn't happy, you actually can go get a bunch of ticks put on your body to feed, and they will take good care of you there. The ticks will feed, and then they'll look at the ticks to see if the ticks have any spirochetes in them. So you can, go to like a spa, like a tick spa, and get covered with ticks, and it's all great. Neurosyphilis, I think that, what time am I supposed to stop? 5? Okay, this is really important. Okay, so one more thing I'm going to do. Just neurosyphilis, and the rest you guys can just see in your handout. Okay, so the reason I want to tell you this is because we often in our clinic see patients that come in who have been demented for 7 years, and someone sent a positive RPR. Don't you guys see that? And everybody says, wahoo! They're demented from neurosyphilis. Well, wahoo is not really the right response. So what you want to do with a positive RPR is send a treponema pallidum specific test, the FTA or the TPPA. Oops. These are non-specific, okay? You got to make them more specific. If one of those is positive, tap. These are the keys. A positive CSF VDRL, treat for neurosyphilis, except if it's bloody. Then again, you don't know what you're doing with it. Another important point, if you have an elevated white blood cell count and or protein concentration, treat for neurosyphilis. But here it comes. If there's no pleocytosis and there's a negative CSF, FTA antibody response, no treatment is required. Positive VDRL, treat. A negative FTA antibody in CSF, no treatment. And what do you treat it with? You treat it with aqueous crystalline penicillin G. The question becomes, who do you treat, right? So patient's been demented for 7 years, positive RPR neurosyphilis, you stick the IV in them or in yourself? Seriously. I mean, you're going to stick it in them. I know that part. But after 7 years of dementia, I don't think we're getting anywhere. So I'm going to stop here because my time has run out. I'll just put this slide up before lunch just because it still goes. The rule from many years ago still goes. You have the rest of my slides. You have the handout. And it's been a joy to be with you this morning. Thank you very much.